We look forward to hearing from you on cytoreduction of liver tumor.
Thank you. Okie dokie, well, hi. How's everybody doing after lunch? Time for the nap? Obligatory postprandial nap coming? Well, I'm not Chinese. One of the reasons why I think Dr. Wang and I work well together is that another thing you need to know about the Oriental mind is patience. They are very patient people and are willing to spend time doing what needs to be done and think about things in a way to get things done. And so I'm not the smart guy, I'm the plotter, and at least I don't have a partner that keeps hitting me up the elbow and saying, come on, hurry up, come on, hurry up. So I think that's one of the reasons why our team works well together, is that we kind of have a simpatico mindset, even though we come from opposite sides of the planet. So today I want to talk to you a bit about cytoreduction, which just means reducing tumor burden by hook or by crook, by whatever means is at your disposal. Before I get too far along in this little gizmo, let me make sure that I have it right. Okay, I found it. There's too many little buttons on this thing. I have a rotary phone at home. Okay. Yeah, what's that? Somebody said, I keep it out because when college kids come over and high school kids come over, they want to make a phone call and say, can they borrow the phone? I said, sure, it's right over there. And they pick up the phone and they look at it. How do you work it? There's no buttons. Yep. Green button is pointer, and that's forward. Yeah. Okay, we're good. So, basically, cytoreduction we can do for all sorts of reasons. We want to improve symptoms by taking away the tumor burden if the tumors are causing, by virtue of the products they produce, by virtue of their location, if they're pressing on something, or they're destroying something or constricting something that you would otherwise not want to have constricted, such as a vas deferens. There are all kinds of ways to reduce tumor burden. We have non-surgical methods. We can embolize, which means using the blood supply to a tumor as a highway to attack it, and putting something in the bloodstream and shooting it off into the tumor by some means of some agent that's designed to hurt the tumor. We can use what's called chemoembolization, where we mix the particulate matter with chemotherapy, and it goes up in there and clots in the tumor and obstructs its blood supply and deposits chemotherapy and has it stick there. Or sometimes knew there's too much technology here. Let's see if I can make this thing be quiet. So anyway, we can put non-chemotherapeutic agents up into tumors, or we can put radioactive materials up in the tumors. You're going to hear about some of that stuff. Or we can surgically debulk tumors. We can do it through percutaneous methods, where we stick things into tumors and apply some kind of an energy source to try and basically cook them. We can do it laparoscopically through little bitty keyholes, or we can do it through open procedures. And we use different types of energy ablations in all of those modalities. And then I guess the most dramatic type of debulking would be just transplant and remove the offending organ and replace it with a fresh one that doesn't have any tumor in it, which is another sort of the extreme example of cytoreduction. Excuse me, let's talk a little bit about the embolization part. So this would be an angiogram of a blood supply to the liver, and that big basketball-looking thing that you see there, I can't quite see that screen very well, but I think I'm pointing at it. You can get the idea. There's some big round globular thing there with a blood supply to it, and that's that big old tumor there. And so we shoot some chemotherapy mixed with clotting agent in that tumor, and sometime later, that tumor is starting to basically die and fall apart. The problem with that technique is that you have to have a place where you can approach it and not do great damage to the organ of interest that you're trying to fix. The liver is fortunate, it has a dual blood supply. Blood comes to it from the intestines by way of a thing called the portal vein, which is also how tumors sometimes get there, as well as by way of the lymphatics. And it also has an arterial blood supply. So if we impact on the arterial blood supply of the liver can still live on that portal vein. It's unique in that characteristic, and so pancreas doesn't have that, kidneys don't have that, and so whatever part of the pancreas or the kidney you would embolize, you would kill. And so the risk is you would kill the entire organ when you do something like that. With radioactive particles, if they get loose from the liver and go into a part of the intestine, you could get a radioactive burn and cause an ulcer to some part of the GI tract. And then eventually, if you embolize, say, the liver enough times, there's a high likelihood that sooner or later the artery is going to occlude, and then it won't reopen or what we call recanalize. Sometimes they do, but sometimes they don't. And now that highway is blocked. So one of the things when you're considering embolizing a tumor in the liver by whatever method you're going to throw up in there, you want to decide, well, are we going to need to do other things to this liver later, and what kind of embolizations do we want to do? Say if you do the chemoembolization first and the artery occludes, you've now closed the door for a radioembolization later. So in our practice, we typically do radioembolizations first, if we're going to embolize. It doesn't close the door for us, usually, to do the chemoembolization later. The bigger problem with the embolization is that it really can set up a really intense inflammatory reaction, and the liver kind of doesn't like it. The tumor doesn't like it either, but neither does the liver sometimes. So you get a lot of inflammation, a lot of scar tissue, and then that makes our job a little harder when we have to get in there and try and take that scar tissue loose from that liver to get to the liver to get the tumors out of it. And so we usually like to leave our embolizations in general for when we're done with the last operation we think we're going to have to do to that liver, now we're going to embolize it. The other advantage to maybe surgically debulking the liver first, if you can get a lot of big, huge things out of the liver, you have less to embolize. Embolization is not necessarily perfect. Now, sometimes you'll have a dramatic response like you saw, but a lot of times, really big tumors don't necessarily respond as well as little ones to embolization. So you have to think about those kind of things. Well, a couple of things that have been around for a while, radio frequency ablation, called RFA, we use the abbreviation, and then a newer technology, it's a similar idea, it's called microwave ablation. Basically, it's a different wavelength of energy. You're using high frequency electric energy. The instrument that you would insert into the tumor, they're like radio waves, but it's the thing you inject that you're sticking into the tumor is like basically a radio antenna or a microwave antenna, and the energy that comes out of there is transformed into heat. And so you're basically cooking tumor like you boil an egg in the microwave. And the microwave is a little more recent. The instrument is usually inside of a hollow needle, and when you deploy it, these little tines have memory, and they take a shape like an umbrella, and they come in various different sizes and configurations depending on what size tumor you're trying to approach. And you're using, typically under ultrasound guidance, after you cook one of these things, then, I don't know if you can appreciate it, it's kind of a bright center where the kind of the increased blood supply around the edge of it is kind of an inflammatory response, but then the dark hollow center in the middle, those are dead tumors. It's not a perfect end-all, be-all, and cure-all. It depends upon how much energy you apply, how long you apply the energy for, the configuration of the tines and how they're placed in the tumor. And sometimes it requires multiple applications in different directions because you're trying to kill every cell and you don't always know whether you're going to do that or not. We try to in every case. But the problem is they generate heat. And heat can hurt things that you don't want to hurt, like in the liver, like bile ducts and blood vessels, or maybe a pancreatic duct in the pancreas, or something near the ureter or the kidney, or intestines. If you're too close to the bowel, you can't cook the bowel. You're going to be close to the bowel, it'll perforate, and you'll have a big problem. So there are some limitations with that heat type of ablation technology. We can also surgically ablate things and cytoreduce with open procedures, with laparoscopic procedures, and sometimes we can blend our procedures. Sometimes patients are challenged with a tumor burden where, I don't know if you can see this kind of scar-like stellate scar. That's tumor wrapping itself around the blood supply to the intestine, trying to choke it off. There's a blood vessel going right down the middle of it. And now you can see that blood vessel. If you kind of visualize that white line coming down that's all gnarly, you kind of almost visualize a hand squeezing around it squeezing off the blood supply to the intestines. Several branches that should be there, are not there anymore. They've been obliterated. It should be branching like the branches of a tree, but there's branches missing here. There's some little strings here that should be big like this middle one. And so you can sometimes peel these tumors off of these blood vessels before they completely kill the blood supply to the intestine, which will lead to intestinal gangrene. At the very least, this causes a condition called intestinal angina. Like people have angina when they get chest pain with not enough blood to their heart. People get belly pain after a meal because they don't have enough blood supply to their gut. So then they have food avoidance because it hurts every time they eat. It's intestinal angina. It's a known entity, and it's very difficult to sort out. Is the belly pain from a partial bowel obstruction? Is it intestinal angina? Is it carcinoid syndrome? Is it other? And you can see here, again, a tumor in the bowel. Here's some lymph nodes with that scar formation. It's kind of squeezing in and drawn down together. And so you want to start finding those lymph nodes and peeling them off of those blood supply and get the blood vessels freed up. And eventually, you can have the blood vessels completely cleaned up and freed up, and now the intestines say, oh, thanks, I needed that. They can breathe again, and you can have better circulation to the intestine. And so that's another reason to do cytoreduction, say, outside the liver. Now, we've seen a bunch of patients with this problem, and now we probably have about twice that many, if not 3 times. But the problem with this problem was that this is called the mesenteric root, right where the main blood supply of the intestine all comes together and exits. And so blood going to and coming back from the intestines is getting choked off by these tumors. The problem is trying to differentiate that between an intestinal obstruction and intestinal angina because the symptomatology is very similar. The main take-home message is that the majority of these patients were sent to us as unresectable. And we're basically told to make a short bucket list. The pain can be debilitating, and they were told that you're going to just have a big, huge pain one day and your intestines are going to die, and that's going to be that. And we just sort of didn't like the way that sounded. So we thought maybe we could do something about this, and we had a very brave patient who came to us some more than 10 years ago or so now, who had this problem, and he was our very first patient who said, well, I don't want to just die, and I kind of want to continue doing what I'm doing. I'm a retired minister, and I do locum tenens for ministers and missionaries and give them a day off or week off or a month off so they can go back home visit their family. And he couldn't do that anymore because he was hurting all the time every time he ate, losing weight. It took us about 14 hours to clean out his intestines like this, but his problem resolved, and he went another 10 years continuing back well into his 80s, doing locum tenens work again and doing his missionary work around the world. So for him, it was probably worth a 14-hour operation. So we can do blended technologies. We can radiofrequency ablate, and there's the needle is in the liver, and the energy is being delivered, and these little white things are actually microbubbles of the water in the cells turning to steam from the heat. And so it's cooking the cells like you cook an egg. You can resect parts of the liver and get some tumor out, and you can resect the primary tumor and its big bulky lymph nodes and all that sort of thing. So, having said all that, new kid on the block is this technology called the nanoknife. The technical term is irreversible electroporation, the abbreviated IRE. And it's different, and it's kind of a unique technology. It uses electrical energy. However, it's a very high voltage at a very low current. Now, you hear the term nanotechnology all the time now, and nanoparticles and all that sort of thing. I had to think about that a little bit, about how big was a nanoparticle. A nanometer is a billionth of a meter. That's T. Einstein. And so a nanoampere is about a billionth of an amp. And 1 amp coming through the wall here is about 100 watts of energy coming out of the wall at 1 ampere at 100 volts. So it's very high juice, 3,000-4,000 volts, very brief moment of time, very brief amount of current, and it acts like a microscopic lightning bolt. And it punches holes in the cell membranes, and then all the stuff that's supposed to be in there kind of leaks out and falls apart, and the cell just kind of falls apart and dies. cool thing about it, it doesn't destroy the skeleton of the organs, and it doesn't destroy blood vessels and bile ducts and pancreatic ducts and ureters and things we like to not cook, because there's no heat generated with this. That's the other neat part about it. It's a little bit tricky to use, kind of like the radiofrequency ablation, because you have to place very sharp, pointy things into places. You can sometimes do it percutaneously, like into the liver here. Many times it's a double needle configuration. Sometimes you use 2 or 3 or 4 needles, depending on the energy field you want to describe and where you want to deliver the energy and where you don't want to deliver the energy. But you can place it very close to blood vessels, in tumors that are very close to blood vessels. The trick is don't put the needles through the vessel or through the bile duct, but you can put them real close by and you won't cook those structures. So we've been very pleased so far. I must say we've been using it not quite a year now, but we've been impressed so far with the results we've been seeing. And just to give you a little bit of an example, so how this all kind of puts together, we had this young patient come to us who was having flushing and diarrhea. She didn't come to us initially. She eventually, she was an avid horsewoman. Got knocked off her horse, goes to the emergency room because she was having some pain in her upper abdomen. That she got her obligatory CAT scan because you don't go to the emergency room without getting a CAT scan. And they said, "Oh, look at that!" And they found a tumor in her liver, and they started her on some sandostatin. And so you have this big old tumor in your liver. We don't know where it's coming from, but you probably ought to go see somebody. So she went and saw a specialist in a specialty center. They said, "Well, you're not a surgical candidate, and here's why." She had this big tumor. I'm sorry for the quality of this scan, but I just couldn't spiff it up any better. But she had this huge tumor in the center of her liver that was splaying out the vessels, and the arteries and the veins coming into her liver were being displaced and squished by this thing. It was smack dab in the middle where all the good stuff is. That's a bad spot. And she was told that she was not a surgical candidate. So she got a little bit worse, and so she got put on a clinical trial of some chemotherapy. That didn't work, so she went and got a third opinion. So they thought, well, she ought to try to embolize it and maybe shrink it with radioactive beads. The problem is, in her case, because it was a big tumor, the beads didn't work that well. Helped her symptoms for a little while, then she got worse again with more flushing and more diarrhea and fatigue and so forth. So then she went and got a fourth opinion at another center, who said, and that center says, well, you really ought to be evaluated by an experienced surgeon and see a transplant surgeon. So she went to that center. She didn't get to see the transplant surgeon, but that was the option she was looking at, was just get a new liver. And so one thing led to another, and she eventually, though, ended up at our center. And here's her tumor. As you can see, it's also, not only is it killing the arteries and the veins coming into the liver, but this is the vein leaving the liver, and it's being pinched off by this thing. There are 3 veins to the liver that empty the liver back into the bloodstream. 2 of those are gone, and the third one's about to go. So she was getting close to being in trouble. Well, what we did was, we did a combination of things by using a combination of surgical resection, nanoknife to take care of the borders of this thing, and some radiofrequency ablation as well, away from the vessels. And now that vein that was previously squished, flat, is now nice and fat. You can see it right here. Nice and flowing, and her liver is happy. And this big hole in the middle of her liver is where the tumor used to be. And it was a challenging operation because there was so much hypervascularity around the edges of the tumor, which was a little unusual. We're not used to seeing that. And we think it was because perhaps the response of the tumor from the hit from the microspheres that hurt the tumor, which took away some of its blood supply, the tumor didn't like that. So it says, I'll show you. And it fought back and got even more blood supply around it to try and feed itself. And there was this hypervascular response, tremendous amount of scarring around the liver, which was a bit of a challenge in itself. But eventually, we sort of got the thing figured out. This was our Artria scan, and this big white basketball is the tumor. That's not her liver. The other 2 smaller, lower things down are the 2 kidneys, and they always light up. So her tumor in her liver really was hot on Artria scan. And now this is her Artria scan. And just as an aside, I don't know if you can see it, but there's a little faint glow up by her, at the base of her neck there. You can see it. I don't know if you can see it on this side, up in there. There's a little faint shadow. So the liver, as you can see, is clear now. A little bit later, we went and did the radio-guided thing and got the lymph nodes out of her neck. And now her chromograninase are normal, her pancreastatins are close to normal, her neurokinin A came down, her 5-HIA is normal, and her flushing and diarrhea are practically non-existent. The other lesson we learned from this case is that her primary tumor at operation, she was one of these, quote, unknown primaries. She had a 1 centimeter tumor in her terminal ileum, and we used the lymphatic mapping to save her ileocecal valve. And the classic textbooks say, well, if your tumor is 1 centimeter or less, don't worry about it. It doesn't metastasize. It's just a carcinoid. Ruh-roh. Wrong thing. So we're learning things that carcinoids are not all carcinoids are not all carcinoids. Everybody's biology, looks like fingerprints, is different. Everybody's tumor is a little bit different. She had positive lymph node, only one, but that was enough. And she had this 13 centimeter cantaloupe in her liver. The things to consider when we're talking about these big operations for little tumors is that complex liver resections, mesenteric dissections, and transplantation are not prospective randomized controlled studies. And they probably never will be. They're extreme examples of operator-dependent outcomes. Just like we say, ultrasound examinations of the belly are very operator-dependent. You can have a really skilled ultrasound tech, it'll give you great pictures. You get another ultrasound tech examining the same abdomen, and you don't know what it is you're really looking at. Just one of those things. Non-resectability, and even in my own practice, there's probably patients that I would not have operated upon 10 years ago that I would probably operate upon today as my skill sets are improved. And we have newer tools and technologies, and our whole team has gained experience. And a big chunk of our team is we've kind of cobbled together from our old liver transplant group. And so that assessment of a patient as non-resectable is a moving target. And maybe they're not resectable right now, for whatever reason. Either because nutrition needs to be fixed first. They're just too malnourished and wouldn't tolerate a big operation. It's probably best the decision to be made by a multi-specialty group, by a team that includes an experienced surgeon, that can sort of understand some of the exigencies of how a complex liver resection will interact with a complex mesenteric resection, with a complex bowel surgery, with lymph node dissection, and all the modalities we have at our disposal, including lymphatic mapping, including radio-guided surgery, and including the tactile part of the operation, where sometimes you find these tumors by feel as much as you find them by sight. And the problem with laparoscopic surgery, it's a line of sight operation, and you miss the tactile part about finding tumors in the gut, for instance, that you would not find otherwise if you didn't feel. And the most tumors ever found along a piece of bowel was 82. That's a bunch. And so we wouldn't have found them had we not been feeling the bowel, because the patient already had a previous laparoscopic surgery, just as a diagnostic thing, said, yeah, there's 1 or 2 in there. Just sort of the eye of the beholder kind of thing. Just limiting our talk to midgut carcinomas, but you could probably say this to any, tumors are not real smart. They only know how to do about 1 of 3 things if they're in the gastrointestinal tract. They can obstruct, they can perforate and necrose and make a hole, or they can erode into a blood vessel and bleed. Carcinoid tumors and neuroendocrine tumors more commonly bleed or obstruct. Rarely do they perforate. Other types of malignancies more likely to perforate before they obstruct or bleed. Some do all 3. They will, in the gut, if it's a midgut carcinoid, they will either occlude the blood vessels and kill the bowel, they will obstruct the bowel and kill the patient, or eventually, if you wait long enough, they will metastasize to the liver, and if left to their own deserts, they will destroy the liver. So we think that every midgut carcinoid and every neuroendocrine tumor is a semi-surgical emergency in one way or another. It's just a question of timing. These diseases are surgical entities that have to be addressed surgically in order to favorably impact the outcome. There are lots of other things, though, that impact the surgical outcome, and there's lots of other things that impact the timing of which thing and which modality do you do first, whether it's a bronchial carcinoid, pancreatic neuroendocrine tumor, or GI tract neuroendocrine tumor. We need to really be able to evaluate patients from head to toe with a multi-specialty group, we need to re-evaluate patients, because sometimes we'll do an initial evaluation of patients and say, you know what, surgery is really not a good idea for you at this moment. We need to do this or that or the other thing. But we do want to see you back to see how that works, and then, or doesn't work, and reassess, and not only just reevaluate and reassess and assess tumor burden, but reassess surgical candidacy, because that's also a moving target, like I said, because our technologies change, our instrumentation changes. There's things we probably could not have accomplished with that young lady had we not had the NanoKnife IRE available at our disposal, which we didn't have a couple of years ago. So that's why I'm saying these things need to be rethought, reevaluated. And so non-resectable just may mean not right now. And we think we're probably on the right track as a multi-specialty group. When you look at outcomes, probably one of the premier multi-specialty groups in the world is Dr. Oberg's group, and you can see his 5-year survival is quite good. The yellow bar is the national average, and because I'm also an LSU purple and gold guy, the purple bar is one of our more recent analyses of about a little over 300 carcinoid patients in 5 years. So I think Dr. Wang also presented you similar data, but we think that we're on the right track, and it's not just a one-man show or a one-person thing. It's having a whole bunch of brains focused on your problem, and everybody putting in their, everybody putting in their assessment and evaluation, because no one person, I think, can really get their head around this whole problem. At least I'm not smart enough to do that. So I rely on a lot of help. We surround ourselves with people of like minds and like interests who are focused on this problem. And I think together we'll probably make some more progress as it goes. So I want to thank you for your time, and hope you have an important
Well, that was absolutely marvelous, and I'm really pleased to see that you're beginning to show that we're beginning to unravel the zebra. If you saw that little cartoon of this there too. So we need to move along and talk a little bit more about what are the other modalities that have arrived on the scene recently that have changed this horizon for us in managing patients with neuroendocrine tumors. You've also already heard Tom Odorizio being on the podium before and how erudite he is in terms of addressing questions with neuroendocrine tumors. Tom and I go back many moons, where the only competition we really did have was when he was at Ohio State and I was at the University of Michigan. And I lost many bets in that regard, and I had the embarrassment with Gene Watering of having to get up on a public podium because I lost the bet, and wearing a Buckeye tie. That actually is a true story. That actually happened. So now you have to ask, I mean, what his background is in neuroendocrine